Hi Abhishek,
Hey Piyush,
welcome to the podcast.
thank you so much for inviting me.
Um, so I read about your profile through LinkedIn and I could see कि आपने सबसे पहले MBBS किया. MBBS के बाद आपने Biomedical Engineering study किया. And this is your second startup.
It is.
And your first startup was also a success. You ran it for close to 13 years and then
Yes.
it got acquired. So my question is, you've seen such a varied experiential journey. लाइक आप डॉक्टर बनते हो तो डॉक्टर में भी आपको इतना मेहनत करना पड़ता है. इट्स अ वेरी स्पेशलाइज्ड फील्ड एंड फॉर टुडेज डॉक्टर्स दे आर वेरी मच कंफ्यूज्ड व्हाट हैपेंस आफ्टर MBBS बिकॉज देयर आर फ्यूअर जॉब्स प्लस देयर आर सो मेनी अदर सेक्टर्स दैट आर इवॉल्विंग बी टेक्नोलॉजी और बायोमेडिकल. So I think you are the right person to answer this question or maybe help junior doctors. Why did you choose or why did you take the decisions that you took?
Great question. So I was always interested in technology, Piyush. मुझे especially how technology could be applied in different workflows. So during MBBS, you get an exposure towards various workflows in different departments. So you get a sense of workflows. You might not be an expert in delivering the workflows, but you get a sense of the workflows. I also understood in my third year of medicine that I didn't enjoy seeing patients. So while I enjoyed the science of medicine, I did not quite enjoy the art of medicine. So that was very clear. And medicine, as much as it is a science, it is also an art. And you have to enjoy that art to be a very good doctor. That's what I feel. I was always interested in technology and applications of technology in workflows. So that led me to a direction which post MBBS I did my M.Tech from IIT Bombay with a focus on biomedical engineering, and it was very organic for me. So like this, every person would have a certain inclination.
Yes.
Now I think in this day and age we are no longer bound by career stereotypes. If anything, probably having different perspectives or having different experiences would make you unique for a small niche, which could be very interesting. So I would say in the 5.5 years of MBBS, that's a long time.
Yes.
So people are also maturing because you typically enter when you're 17, 18, you're graduating when you're 20 to 23. So you're evolving as a person. Your likes and dislikes are also becoming more clear to yourself.
Yes.
So there could be a doctor who's very interested in law, for example, and there are examples of physicians who are doing fantastic in the legal profession or in administration.
Yes.
So I think at this point the typical career roles are great, but if somebody wants to go off the beaten track, I think those opportunities are much more available now than 15 or 20 years back.
And now you're running Butterfly Learnings for last 4 years with your wife. So I would like to know what is your vision and why did you start it? Because in India autism is still considered as a stigma. Maybe there is less awareness about autism, but still you chose to start your journey. Why did you do it?
Great question. So Sonam, my co-founder and also my wife, she's a pediatric neurologist. So she finished her MD PhD from NIMHANS and she came back to Mumbai and started practicing in Wadia Hospital, which is a large children's hospital in Parel. What was very clear from 2015-16 to Sonam, and she communicated it to me, is that the prevalence of neurodevelopmental disorders, not necessarily just autism, but neurodevelopmental disorders as a whole, is rising for a multitude of reasons. That was very clear. What was also very clear is that there is a huge supply-demand imbalance. So if 1 in 8 kids has some sort of neurodevelopmental issue, that is a total of close to 4.5 crore kids in India. And on the supply side, you essentially have only 20,000 speech and occupational therapists.
Mm.
And these 20,000 also are not dedicated towards kids.
Yes.
They're also looking at adults. They're doing post-stroke rehab.
Yes.
So 20,000 therapists can at best look at 2 lakh kids. What happens to the delta?
Yep.
So the supply-demand imbalance was very clear. The prevalence going up was very clear. And we also got a sense that the existing field is extremely disorganized. Nobody is measuring outcomes. So in everything else, for example, if you're treating diabetes, there is a clear outcome. You want to see your HbA1c go lower.
Yes.
But if you are doing the same in therapy, you are aiming towards your child getting better, but you're not measuring. Nobody was measuring anything. So we wanted to bring in something which one solves the supply demand problem, but the moment you scale up supply, there is a risk that you would dilute quality.
Yes.
So we wanted it to be a system which can scale while preserving. So the moment you scale up supply, there is a risk that quality would be diluted. So we wanted to create systems and protocols where we could scale supply without diluting quality. And one big inspiration was what happened in ophthalmology a few decades earlier.
Yes.
Right, where complex workflows, for example, cataract surgery, were broken down into very measurable steps with extreme protocols. And then clinical excellence was delivered. So that is what we wanted to do for therapy. And that's why we started Butterfly.
Okay. You have raised very valid points. So broadly, you have said that there is a problem in the demand side as well as in the supply side. And you're trying to solve both of these problems.
Yes.
Over a period of time, you'll be able to solve them in a measurable and sort of a evidence-based manner.
Absolutely.
So we'll try to dig deeper into demand and supply related issues. So first we'll start with demand related issues. And for that, I would like to show you a reel, and we would like to have a discussion on it after that.
Autism, if I could, I don't want to go too long because we have a lot of people, but the autism is such a tremendous horror show, what's happening in our country and some other countries, but mostly our country. How are you doing on that?
We are doing very well. We will have announcements as promised in September. We're finding certain interventions now that are clearly, almost certainly causing autism. And we're going to be able to address those in September.
It's such a big day. I'm looking forward to that day because there's something wrong when you see the kind of numbers that you have today versus 20 years ago. And those numbers, what are those numbers, Bob?
In 1970, the biggest epidemiological study in history was done in Wisconsin. They looked at 900,000 children, and they were looking for autism. They knew what it looked like, and they were very, very precise about it, and they found an incident rate of 0.7, in other words, less than 1 per every 10,000 children. Today, our most recent numbers are 1 in every 31 kids. It's probably actually much worse than that because California, which has the best collection system, is reporting 1 out of every 19 children, American children.
So here, this video actually is depicting what you were talking about, the demand side. So there are 2 questions. One is in the US, not just general doctors, but the top leadership is talking about autism on the biggest platform. And they're telling that obviously the incidence of autism has increased. As you said, that it's 1 in 31. And they're saying that it can even be as lower as 1 in 20, 1 in 19, 1 in 12. So I would like you to corroborate these numbers from an Indian standpoint.
Sure. So first issue is India does not have a very clear reporting system for autism.
Yes.
And there are no large studies except one that was done in NIMHANS in 2018, from where all of these numbers that I'm quoting, 1 in 8 kids has some neurodevelopmental issue. That is from that study. But there is no government mandated large reporting system for autism and neurodevelopment. that we have in India, unlike the US.
Yes.
So US has, done a very good job in creating reporting sites. Now the incidence is clearly going up.
Yeah.
There are multitude of reasons behind it. The first reason is that the diagnosis itself has broadened, and the thought process is that we want to help as many kids as possible, but that also means that you're extending the diagnosis. Second, awareness has gone up.
Yeah.
So these are two confounding factors that we have to keep in mind. But if you go to a school today, if there are a class of 25 kids, you will see 1 to 2 kids who have some sort of neurodiversity. So just anecdotally, that is what you would see in a classroom.
Yes.
The same is corroborated by pediatricians in their OPDs, where every 1 in 8, 1 in 10 kids has some sort of neurodiversity. So anecdotal, in India, we just have those anecdotes.
Yes.
We don't have hard research-based reporting on numbers. But if you go by the anecdotes, 1 in 8, 1 in 10, these are very reasonable numbers.
Okay.
And it could be more. It could be more, but not less.
So you're saying that, let's say if we go back in 1970 and had there been more diagnostics or more screening, the numbers could have been even higher, even at that time.
Piyush, any economy, any country goes through levels of or waves of disease.
Yes.
The initial mortality and morbidity comes in from infectious disease. As the economy and the country moves forward, the burden from non-communicable diseases goes up.
Okay.
The third wave is mental health. So any country that you pick up, you can pick up Japan, you can pick up Africa, they are at some place in the continuum. In India, we have all three.
Yes.
We have kids who are dying of diarrhea, which is causing infant mortality. Diabetes and hypertension is everywhere.
Yes.
Prevalence rate of incidence rate of cancers are rising, and mental health issues are being reported much more in kids as well as adults. So it's a complex question to answer.
Yes.
But in 1970s, I would believe a lot more countries were in the initial phases of development. At least India was definitely in initial phases of development, where a lot of mortality was due to infectious disease. And the first priority was to control the mortality because of infectious disease, as it should be.
Okay.
And once that gets resolved, you have mental health and non-communicable diseases that start showing up.
So basically you're saying as we are evolving, the focus is shifting towards mental diseases or brain related diseases, because now the infections have already been solved.
Correct.
Even though India is a little lagging behind, but still the solutions are already there.
Correct. Or getting better. Okay. So if you look at our infant mortality rate, we've gotten a lot better in the last 10 years.
Definitely.
If you look at maternal mortality, we've gotten a lot better in the last 10 years. So now when infant mortality, maternal mortality are getting better, total lifespan is increasing of people. That's where you have more of non-communicable disease and then mental health issues that start cropping up.
Okay. So from demand perspective, so you have 75 clinics all over India, and through those clinics you are providing therapies to cure autism and
to manage autism.
Okay. Yes. And from the diagnostics perspective, you are trying to bring in new technologies and new therapies to screen children as early as possible. So these are the two things as far as demand is concerned. These are the two things that you're doing. So would you like to comment on it?
Sure. So we look at it as a continuum. So the first thing that we realized in year 2 or year 3 of Butterfly is that kids are coming to us at a median age of about 4 years. And we have collected data from every child from every session from day 0. So we are probably the largest longitudinal database of neurodiverse kids in India.
Okay.
From that, we can say, and there's research to back it as well, that the earlier you start your therapy, the better outcomes we are able to deliver. So we really wanted technologies and ways in which we can catch kids early, as early as their second year of life. And that's where the outcomes, the clinical outcomes have been best for us. And that's where we got in Get Set Early from Dr. Pierce's lab in UCST, which uses eye tracking to diagnose autism. I'll say diagnose because the specificity is extremely high. I'm not using the word screen, but that's the thought process. Yes.
Okay. So broadly, you talked about two demand channels. You said that kids are in school, and schools, 1 in 10, 1 in 8 children might be suffering from autism or some neurodevelopmental issue. Similarly, by talking to various pediatricians, the similar numbers have been quoted. Other than this, how are you creating awareness? Let's say if parents are also able to see that their children are not developing as fast as other children, so are you directly reaching out to parents also for awareness?
Piyush, you're doing a fantastic job in creating content, and we hope that we can create much more content like this, which is able to. So there are 3 stakeholders in this equation.
Yes.
First is parents. So we feel that parents, especially the mother, very early in life gets a suspicion that the child is not developing at par with others.
Yes.
The second is the pediatrician, because in the first 3 years of life, there are multiple instances that the child is visiting the pediatrician for vaccinations and for
Wellness,
regular wellness checkups or illness incidences. And the third is when the child is 3 years old, starts going to a preschool or a school, and then the class teacher picks something up. So these are the 3 places where we need to increase awareness.
Yes.
And we need content, we need support from creators like you to work on all of these 3 stakeholders. Really.
So thank you for giving me this opportunity. No, for example, you said that कि एक मदर को सबसे पहले पता चलता है, या फिर आप स्कूल जाते हो या प्री स्कूल जाते हो तो टीचर माइट नोट इट. सो देर इज़ दिस पॉसिबल गैप. मान लीजिए कि बच्चे को इशू पैदा होने के 3 या 4 महीने में विजिबल हो जाना चाहिए था, बट देयर वाज नो टेक्नोलॉजी. सो दे वर लुकिंग फॉर बिहेवियरल क्यूज जो पेरेंट्स ने माइट नोट कर लिए या पीडियाट्रिशियंस ने शायद देख लिए, बिकॉज पीडियाट्रिशियंस आर नॉट डेवलपमेंटल पीडियाट्रिशियंस.
Correct.
They
have a good sense.
They have a good sense. But as far as parents and school teachers are concerned, they might miss it, they might not miss it. So probably that is where your technology Get Set Early comes in.
That comes in. There's also a very human element of denial. You sense it, but then you're hoping against hope. You're saying that थोड़ा और time जाने दो. Time के साथ ये सही हो जाता है. Sometimes elders in the home are saying, तू भी ऐसे ही था, तूने भी लेट बात किया. So these things delay, institution of treatment, which can actually be transformative for the child. So वहाँ पे if you have an objective test, कि if you have a suspicion, आप ये objective test करिए, and if the test is giving you a high risk, it's an extremely specific test. Maybe not very sensitive. Sensitivity is only about 65-70% for Get Set Early, but specificity is extremely high, which means that if the test says that you have a problem, the odds of you having of the child having a problem is extremely high. So you essentially save that time, and that time is invaluable, because in that age of 12 to 36 months is when neuroplasticity is maximum in a child's brain. After that, neuroplasticity starts going down.
Exactly. So you're saying that these machines should be installed in schools with pediatricians. These are the 2 major areas where children go.
Absolutely. So either machines can be installed in schools, or you can do camps in schools. Okay. You per se don't need a machine in every school. That could probably be wasteful. But you can do camps in preschools and schools once a year during admission, maybe with a wellness checkup. It should definitely be there as a tool with pediatricians, so that they are able to catch kids early.
And it is as simple as possible. You're saying that like camp happens once a day, in one day in a year, and let's say there are 200 children. All of those children can be diagnosed or screened in a
So-
single day. It's
So
a very
one test takes about 10
10 minutes.
minutes. So maybe in 1 hour we'll be able to screen 6 kids with one machine. But in this setup, there is no you can always have multiple machines.
Yes,
You can have 6 machines
6 machines.
which are dedicated for school camps, and or 10 machines that are dedicated for school camps. Extremely easy to use,
Yes.
and you can finish the screening in one day.
Very nice. So, okay, this brings me to the question of supply. I'm assuming that you have installed these machines in your existing clinics,
Some of us,
and you have started getting data also.
Absolutely.
And I'm hoping that in the coming year or so, you'll have more data to show for.
We are not only using it for screening and diagnostics, but we are also collecting data to see if it can be used as a prognostic marker.
Okay.
So can we say that if the eye tracking, there are 6 eye tracking tests in
yes.
the GetSet early battery. 3 are visual, 2 are gaze contingent, and 1 is related to audio. So can we see patterns of kids failing the test, of what kind of eye tracking tests are they getting a high score on? And can we correlate it to the kind of autism? Can we create clinical phenotypes? And can it inform the intensity and the protocols that we have to deliver in their individualized therapy program?
Okay.
So this is our first step towards getting into precision medicine in autism and neurodevelopmental disorders.
So in simple words, you are collecting data and you're using that data to personalize the therapy.
Absolutely.
Eventually. Okay. And this brings me to another question that you also raised, that there are 20,000
Speech and occupational
therapists,
therapy.
speech and occupational therapists in India. And I also did my research. Like from demand side, we took the data, or we learned from the US that there is this problem of 1 in 30, 1 in 12 children. Similarly, I looked at the supply data of US, and I could see that there are 3,000 developmental therapists dedicated to children per million.
Per million, of course.
Per million. But in India, this number is a meager 30. Like,
Right. So it's not even in the same ballpark.
It's not even in the same ballpark. And when I say developmental therapists, there is a list of therapists that you need to have, from ABA therapists to speech therapists, occupational therapists.
Absolutely.
And then you obviously, depending upon the gravity of situation and the number of children you have in each and every category, you have to develop all of these therapists accordingly. So as you said that you're also trying to build this supply, because you have a supply of 400 therapists till now.
Yes.
In all of your 75 clinics.
About 500.
About 500. So what is your plan? Let's say, I was also checking some numbers. They might be wrong, but they give a good estimate. There are close to 15 to 18 million children suffering from this. This is just a back of the hand calculation. I might be wrong. You can correct me anytime. So how many developmental therapists do we need?
Okay.
And are we working towards it? How many are we producing every year?
Sure.
Yeah.
So let's break it down.
Yes.
So as to and autism and neurodevelopmental disorders don't need just one kind of therapy.
Yes.
They need a combination of therapies. So who are the people that a child needs? First, the child needs developmental pediatricians or pediatric neurologists to accurately diagnose the problem. Second, you need behavior therapists or ABA therapists. You need speech therapists. You need occupational therapists. And if there are any sort of physical symptoms involved, like in cerebral palsy, you might need a physiotherapist. Then you have schooling. In schooling, you need teachers who are trained in handling neurodiversity. And in the absence of that, you probably need shadow teachers, which is not the best. But so these are the gamut of people that one child needs for a proper well-rounded treatment. Now, first is developmental pediatricians. So there are very few developmental pediatricians or pediatric neurologists in India. As Butterfly, we really want to start an institutional fellowship so that we are taking pediatricians, we are giving them a year-long training on different facets of autism and neurodevelopment, and then hopefully they are able to help a lot more kids in a much more nuanced way, because this, as you said, the prevalence is growing up. Second is how do you scale therapists, which is the bottleneck.
Yes.
Now this is very tricky. If you create therapists fast, and you have boards that are now coming in like CABA, Qualified Applied Behavior Analysis Board, that are helping in creating behavior therapists. You have speech therapist colleges coming up. You have occupational therapy colleges coming up. But if you scale therapists too fast, there is a risk that you would be diluting quality. So that is where protocolization, use of technology, where you are measuring inputs and outputs very diligently as part of your workflow, like we do in Butterfly, becomes extremely important. So not only do you have to train your therapists to deliver care in a protocolized yet individualized way. So this is very interesting because every child needs an individual therapy plan, but this therapy plan is created of individual protocols, which are like letters. You can use letters in different ways to create sentences, but the letters by themselves are standardized. So those sort of protocols become extremely important. Measuring outcomes becomes extremely important as you are scaling supply, and these outcomes need to be transparently shown to the parent and the pediatrician and the school.
Okay.
Because that is the community that is with the child as you're as you're delivering care. So it becomes extremely important to not only scale supply, but also have a technology layer and a quality layer to ensure that your quality is not getting diluted.
So to summarize what you said, तो फ्रॉम अ पेशेंट जर्नी पॉइंट ऑफ व्यू मान लीजिए पेरेंट्स को स्कूल में या पीडियाट्रिशियन के पास में पता चला दे गॉट दिस गेट सेट अर्ली टेस्टेड, आई ट्रैकिंग टेस्टेड, तो वहाँ से उन्हें एक स्कोर मिल जाएगा जो पेरेंट्स को बहुत अच्छे से समझ आ जाएगा, क्योंकि 0 to 100 के स्केल पे आप एक स्कोर दोगे, उस स्कोर के बेसिस पे दे विल बी रेफर टू अ पीडियाट्रिक न्यूरोलॉजिस्ट और अ डेवलपमेंटल पीडियाट्रिशियन. वहाँ पे उन्हें डायग्नोज किया जाएगा एंड पूरा एक थेरेपी का एक इंडिविजुअलाइज्ड थेरेपी का एक रिजीम और रूटीन प्रिपेयर किया जाएगा, एंड ऑन द बेसिस ऑफ दैट रिजीम उनको डिफरेंट थेरेपिस्ट के पास भेजा जाएगा, विच कुड बी अ स्पीच, अगर स्पीच डिले है तो स्पीच थेरेपिस्ट के पास अंडर द सेम प्रोग्राम, एंड अगर और चीज़ों में है तो और चीज़ों में भेजा जाएगा. इस पे आप ऐड करना चाहोगे, क्योंकि काफ़ी मैंने जेनेरिक तरीके से बताया सोल्यूशन. फॉर एग्जांपल आप शायद मैं पूछूंगा भी सही आपसे बाद में, बट आप इसको थोड़ा और कॉन्क्रीट तरीके से, स्ट्रक्चर तरीके से बताना चाहोगे?
श्योर. तो पहले स्क्रीनिंग हो रही है, बिल्कुल, आइडियली एज पार्ट ऑफ अ wellness checkup for a baby in the first 12 to 24 months of life. वहाँ पे we are able to catch kids early. जो भी high risk या moderate risk kids है, they go to a developmental pediatrician. वहाँ पे there is a medical opinion that is formed. I won't use the word diagnosis too strongly, because a lot of really young kids, we don't give a diagnosis. We say symptoms. And then there is an individualized therapy program that is created for the child, and then it is delivered in a way जहाँ पे आप हर एक सेशन, हर एक प्रोटोकॉल में आप मेजर कर रहे हो कि आप क्या दे रहे हो और उसका आउटकम क्या है.
Okay.
और वो आउटकम, फॉर एग्जांपल आई कांटेक्ट, अगर आप आई कांटेक्ट पे काम कर रहे हो, आप मेजर कर रहे हो कि आपने कितने प्रोब्स किए, वो बच्चे का आई कांटेक्ट कैसे इम्प्रूव हो रहा है ओवर अ पीरियड ऑफ टाइम.
ओके.
एंड देन वो ग्राफ आप पेरेंट को दिखा रहे हो,
okay.
वो ग्राफ आप पीडियाट्रिशियन को दिखा रहे हो इन अ ट्रांसपेरेंट वे. और अगर बच्चा सुधर नहीं रहा है, वो भी ग्राफ आप दिखा रहे हो.
okay.
तो ये हो गई द एविडेंस एंड डेटा इनेबल्ड थेरेपी डिलीवरी. उसके साथ वेरी इंपॉर्टेंट टू ऑल्सो गिव होम प्लान्स एंड एजुकेट पेरेंट्स, क्योंकि थेरेपी एक बच्चा हफ्ते में 6 घंटा लेगा, बिल्कुल, बाकी टाइम तो घर पे होगा, स्कूल पे होगा. सो वी हैव टू इंश्योर कि members of the family are also delivering home plans when the kid is not in therapy. So uske liye, for example, we have a parent application.
Okay.
Jahan pe not only you can check the child's progress, but you can also look at different home plans and deliver it to your child.
Okay.
There is a lot of innovation that is possible on that front, and we are just scratching the surface, so to speak. So that is aapka evidence-based therapy, parent-enabled home plans in one application. The second big bucket is the help that the child needs in academics and in school, which is inclusive education.
Yes.
Creating curriculum for specific neurodiversity and then delivering it in a way which is appropriate for that child's ability, and also helps in overall integration of the child. That is another very big bucket. So we have something called BLISS,
Yes.
Butterfly Learning's inclusive schooling system, where we have curated curriculum and teaching methods for different neurodiversity, and we are working with schools and delivering inclusive education with the help of schools.
Okay.
So that is the next big bucket that is there.
So in schools, what happens is, school mein you open your own therapy center. So it's and you run it for them.
So
This is the
what
model.
we do is, it's called a resource room.
Okay.
So a resource room is very similar to a therapy center, but inside a school.
Yep.
And then kids are coming in from different classes with specific issues. So one child could be dyslexic, has trouble reading. So how do we teach English to that child?
Okay.
So that is essentially what we are solving for. There could be another child who's really not at the ability to get in or to cope up with CBSE or ICSE. So can we take that child to NIOS? Can we curate academic curriculum for that child? But everything non-academic, the child is still interacting with their neurotypical peers. So that is important not only
Yes.
for the neurodivergent child, but it's also important for the neurotypical child, because neurotypical children also have to learn how to deal with diversity.
Correct.
So I think it's one of the
Yes.
experiments that we have run in Butterfly that we feel very confident about scaling from multiple perspectives.
No, I really feel that this bliss is more important.
Absolutely.
Because otherwise, in the old times, like I know that my mother used to take tuitions, and there used to be kids. Now I can imagine that they were, there were some delays in development. But at that time, we used to call them different names. So looking back, I feel that, the kind of this bliss, the concept of bliss is very, very critical to create this inclusive society.
Absolutely.
Probably it will teach children empathy early on, which is very important. So one question always keeps coming to my mind. I had asked Dr. Sonam also and Dr. Karen also, what is happening inside the mind of the child? So I could find one image, and I would like your comment on it. What do you understand from this image?
That's a great representation.
Yes.
That's a great representation.
So from a layman perspective, I could understand some bit that a neurotypical child means normal child. His or her thinking is straight, in the sense, let's say if you have told them to do something, there is a high chance they will do that. It is easier to teach them, probably.
Correct.
And similarly, better you explain it.
So, we use the word ADHD very loosely.
Yes.
But what ADHD means is that the child is having trouble sitting or engaging in every task. And that causes a lot of issues in the child's development, in the child's academics and thinking. Imagine if you are not able to concentrate on something for more than 20 seconds. How distressing it would be. And this is a biological issue. It's not a social issue. It's a biological issue.
Okay. No, some people might think that let's say if you're using screens so much, you might have ADHD. It's a very generic statement maybe I'm giving, but still, this is one of the myths that I've found in people.
So I think what is happening now is we are also over medicalizing terms. We are using terms very loosely.
Very loosely.
For example, people say I'm depressed. Clinical depression, there's a definition. You're not depressed, you might be sad, which is not depression. So if a child has ADHD, it's a clinical condition where the child is unable to focus their attention for a very long period of time on all tasks. And it's extremely distressing. Autism is a spectrum.
Okay.
So, you could have kids with what is now called profound autism, where there are autism like, where you have social symptoms of autism along with low IQ. You could also go on the other end and you could have autism with extremely high IQ. So autism by itself is a spectrum. And every person in that spectrum sees the world differently.
Yes.
And that could be a massive advantage as well. They could probably see the world in a perspective that neurotypical kids just can't.
Yes.
Right. So that is extremely interesting. And then you have autism and ADHD coming together. And it's that that spectrum suddenly gets more random, right? And that's probably what the diagram is showing.
So in case of autism, like you said, there is a spectrum in which the child could be a genius.
Yeah.
Could be a mathematician or computer science. Or
it is called Asperger's syndrome.
Asperger's syndrome.
Not sure if it's part of the DSM, but it was called Asperger's syndrome.
Okay. So we can say that just, like in Doctor Strange, the movie Doctor Strange, like Doctor Strange has this power to sit and think in all random directions.
Right.
What could happen, A, B, C, D, E, F. Like a normal child will think from going from A to B. So can we say that an autistic child might behave like Doctor Strange? Because Doctor Strange was a genius.
Especially if kids who are on the spectrum and if they have extremely high IQ. We've seen kids with savant-like skills. I remember a child in Butterfly who had eidetic memory in the sense that he could draw a picture of whichever scene that he was put in to the last detail. In the sense, where is the laptop kept? There's a cup, there's a plant. He remembered everything. That is not neurotypical. That is definitely different. And probably that child would be a fantastic artist or a fantastic creator when he grows up.
So basically it is more critical to understand the child's problems early on. Yes. Otherwise your child could be a genius, world level genius, but you might not even know it, and
the other end is also there.
Yeah.
The child could have profound autism where IQ is low, and you have symptoms, and then the child will need care for a large part of his or her life. And even there, if you catch it early, the magnitude of the disease can be managed. I won't say cured, but can be managed.
Okay.
Clinical outcomes can be better, and integration can still be possible.
Okay. So to all the points that you have said, we'll watch a few small videos, and which will cover all the aspects that you've just raised. And I would like to take your feedback on these videos.
Sure.
So I've grown up with a sibling who has high support needs. He has autism. If somebody were to see him, they would see him as somebody who may not be able to work in the traditional sense. But seeing him now, he's an adult and he works. He's able to make things, do things that people actually want to buy. He makes artwork that he can turn into books and bookmarks and candles and things like that he's able to sell. It gives him a sense of purpose. It helps him structure his day. It helps him understand the fact that, okay, if I do this, then it'll help me do other things. So if I sell this, I make money, and then I'll be able to buy the snack that I like, or I'll be able to buy, the clothes that I want. So I think that understanding of this is my effort, this is something that I am making possible. I think that is extremely valuable to somebody with a disability, because they also want to feel a sense of agency. Like all of us, they also have a sense of agency and would like to feel that agency in their lives. Having employment, contributing, and getting back from it are probably things that they would also feel is just as important as,
This is fantastic.
Yeah.
So, we spoke about therapy, we spoke about education. This is really the next step after education, which is how do you get meaningful vocation? And there are a couple of companies that we really admire. Atypical Advantage, Purple Economy,
Okay.
both Indian companies doing fantastic work in this. But it's very exciting and heartening to see that as a society, we are becoming more inclusive. The companies are hiring more neurodiverse people, and taking education, inclusive education forward is essentially building vocation for
Agreed.
for neurodiversity, and we would love to partner with organizations
Okay.
who are on similar paths.
And family support is very important.
Absolutely.
First, it said it used the same example you just mentioned, that the child could draw anything he or she sees. Plus, like, family support is very important. I'll show you another video and then probably we'll talk more on it.
समस्या ये नहीं था कि उसे ऑटिज्म है, मेरा समस्या ये था सबसे बड़ा, जो एक 3rd स्टैंडर्ड पास मम्मी उसे सॉल्व कैसे करे, कैसे उसे धीरे धीरे दैनिक जीवन में ला सके। तो मेरी सबसे ज़्यादा समस्या थी वो मेरे खुद के साथ थी, कि ऐसा लग रहा था या अभी भी लगता है मुझे कि एक नॉर्मल चाइल्ड के मदर को पढ़े लिखे हो ना हो, पर स्पेशल चाइल्ड मदर को पढ़ा एजुकेटेड बहुत होना ज़रूरी है, क्योंकि अगर मदर और ये फादर नहीं करेंगे तो और कोई नहीं करेगा। सबसे बोरिंग चीज़ था मेरे लिए पढ़ाई करना, और मुझे नहीं पसंद था, लेकिन मैं अपने विकास के लिए आज मेरे लिए सबसे फेवरेट सब्जेक्ट बन गया है कि मैं पहले खुद सीखती हूँ, उसके बाद अपने बेटे को सिखाती हूँ। ऑटिज्म एक ऐसा अपॉर्चुनिटी है जो कि बहुत ही, उसे समझा जाए, सीखा जाए तो बहुत कुछ है, बच्चों के अंदर बहुत सारी चीज़ें हैं, वो हमें देखना है और उसे हमें इम्प्रूव करना चाहिए। जो देखने का नज़रिया है लोगों का, समाज का, सोसाइटी के, उसके वजह से भी ज़्यादा माता पिता खुल के आ नहीं पाते, बच्चों को बाहर नहीं लेके जा पाते, पर मेरा मानना है कि लेके जाना चाहिए। कि कौन क्या सोचता है इससे मुझे कुछ फ़र्क नहीं पड़ता, मैं कैसे देखती हूँ अपने बच्चे को, उससे ज़्यादा फ़र्क पड़ता है।
Can't agree more. Yes. First acceptance is from self and family, and family is extremely important, especially parents, grandparents, siblings, extremely important. But what we are seeing, Piyush, is that generally as a society we are getting more inclusive. We are not looking at neurodiversity differently.
Yes.
I'll give you an example of my daughter's school.
Okay.
My daughter is neurotypical. She goes to a neurotypical school. But in her class, there are a couple of kids who are neurodiverse. Now, when we go for Parents' Day, when my daughter is performing, the school ensures that these two neurodivergent kids are also on the stage.
Okay.
And then you have their classmates who are taking care of them. And they're given some role. Maybe not the main role, but they're given some role.
Okay.
And they are included. And then if a child is extremely hyper, for example, there's somebody who's holding their hand on stage and performing. And, things like that make me believe that, the world is getting better.
Yes. Yes.
Yeah.
And these two videos show that this problem is everywhere.
Yeah.
Like in the first video, the girl was talking in English. I'm assuming that she might be from an urban background, let's say. And in the second video, the mother was not that educated. She was just 3rd class pass. So in both these cases, the point that I'm trying to make is कि ये problem कहीं भी हो सकता है. आपका economic background कहीं भी हो. I'm just trying to.
Yeah, absolutely.
Yeah.
We care for more than 2,000 kids on a daily basis. 50% of kids who come into Butterfly come in from families who have annual incomes less than 6 lakh rupees per annum.
Okay.
That's 50,000 rupees per month. So it is not a upper class problem. It is not an upper middle class problem. It is all over. Unfortunately, we have not, giving therapy is expensive.
Yes.
So I think one big challenge that everybody has to work on is how you can reduce costs of delivering therapy. Maybe create a physical plus digital model.
Okay.
Experiment with different modes of delivery. But that is something that is extremely, extremely important.
Okay. So now that you touched upon the pricing part, so I have another video so that we could take that discussion forward.
$100%. And this said dollars.
This is for the US.
This is for the US. US has, therapy is covered under insurance.
Yes.
And this is after that, right? In India, there are very few insurance schemes that meaningfully cover therapy. You have the Niramai scheme that covers therapy to some extent.
Okay.
But meaningful coverage is still not there for insurance schemes and therapy.
Okay.
So this is even more true for Indian parents because it's all out of pocket.
So can we safely say that autistic parents spend 5 to 10x more than...
Definitely.
Okay.
Definitely.
Okay. And let's say if they're taking therapy, obviously they're spending money on it. And if there is no vocation, obviously the child's earning capability could be lower. So overall, they would end up spending 5 to 10x more.
So again, as I said, it's a spectrum. So on one side, you would have kids with profound autism.
Yes.
And they would need a lot of help probably through their lives. But there's also a bunch of kids who don't have profound autism. Who with early therapy, with evidence-based therapy, with evidence-based treatments can be pushed in a direction where they are excelling, need not excel academically, but they're excelling in whatever they are good at. And I think that's extremely important.
Okay.
So not only caring for the kids who are severe or with profound autism, but also looking at the other parts of the spectrum and then saying how can we ensure that there is maximum integration on that side.
Let's say India is a very like the average salaries are on the lower side. So the point that I'm trying to make from watching this video is that if you know that it is going to cost you a lot in the future, so it's better to take preventive course as soon as possible.
Absolutely. Or you know of the problem as soon as possible so that you can reduce the cost and the pain. That is there.
Okay. And you also talked about society level inclusion.
Yes.
So I want to show you another video, and then we'll see where we are.
Sorry. It is tough.
It is tough. But here, the society is included. The child has been throwing tantrum everywhere, but still, किसी ने कुछ नहीं बोला. People were very inclusive, very calm about it.
In fact, it's probably one of the best reactions I've seen.
Reactions,
where,
yes.
You're not doing anything.
Yes.
You're not enabling. You're not stopping. You are letting the child be, but also you also have to think about the child as to how she's trying to communicate. One, so we shouldn't be stopping her natural communication or behavior, but we also have to make her functional. It's extremely thin line.
Yes. And it is very difficult.
It is very difficult.
कि मान लीजिए चाइल्ड अगर इस तरीके से बिहेव कर रहा है, लाइक मुझे याद है कि मेरी वाइफ भी पीडियाट्रिशियन है, तो उनके क्लिनिक पे मुझे याद है एक बच्चा आया था और वहाँ पे उसका ब्लड सैंपल कलेक्ट करना था. तो जैसे ही ब्लड सैंपल कलेक्ट करना था तो वो चिल्लाने लग गया एकदम. आधा पौना घंटा लगा उसको वो करने में. मदर आई थी, फादर नीचे थे, तो बाद में फादर को ही बुलाया. बट इवेंचुअली आधा पौना घंटे के बाद इतना शोर मचाने के बाद भी ब्लड सैंपल कलेक्ट नहीं हो पाया. और उस पॉइंट में मैं भी वहाँ बैठा था, तो आई वोंट से कि मैं भी माइंड वाइज इतना इंक्लूसिव हूँ. मेरे लिए भी वो, मेरे ख्याल से मैंने ज़्यादा ऐसे बच्चे देखे नहीं हैं अभी तक. तो मुझे ये रियलाइज़ हुआ कि देयर इज़ अ टेंडेंसी कि कोई भी पेरेंट या कोई भी थर्ड पर्सन इसको बहुत ही अजीब बिहेवियर बोल सकता है. दे कैन क्वेश्चन द पेरेंट्स कि यार इन्होंने क्या पढ़ाया लिखाया, कैसे संभाल भी नहीं पा रहे हैं. तो ये एक स्टिग्मा तो है कि प्री कंसीव्ड नोशंस तो हैं ये. इनफैक्ट मतलब मैं अपना ही एग्जांपल ले रहा हूँ कि चलो हम लोग पढ़े लिखे हैं, बट स्टिल एक बैक ऑफ द माइंड में ये था कि यार ये देयर कुड बी मल्टीपल इश्यूज. बट कभी भी हमने बच्चे के पॉइंट ऑफ व्यू से नहीं सोचा कि उसके अंदर क्या चल रहा होगा, भाई उसके लिए कितना डिफिकल्ट है, कितना फियर होगा. तो डू यू फील कि हम लोग इंडिया में दिस कुड बी द आइडियल इंक्लूजन?
आई थिंक we're getting better. It's a long way to go.
Yes. तो एक्चुअली ये इंक्लूजन के बारे में जब हमारी 6 महीने पहले बात हुई थी, तो आपने बोला था कि आपके यहाँ पे जैसे किसी भी बच्चे की क्लिनिक में थेरेपी खत्म होती है तो आप सेलिब्रेट करते हो, उसके पेरेंट्स आते हैं
जब हम डिस्चार्ज करते हैं.
Yes, जब आप डिस्चार्ज करते हो. तो मुझे लगा कि ये बिहेवियर बिल्कुल ही ऑपोजिट है. मतलब जैसे आप हॉस्पिटल जा रहे हो तो आप हमेशा टेंशन में ही रहते हो कि कितना बिल आएगा, कितना क्या होगा. कोई सेलिब्रेट नहीं करता. इट इज़ अ सैड इवेंट. तो आपने जब ऐसा बोला तो मेरे माइंड में एकदम ऐसे कॉन्ट्राडिक्टरी आया कि ये तो इम्पॉसिबल सी चीज़ लग रही है. तो मैंने उसको लेकर के एक वीडियो भी बनाई थी. आई वुड लाइक टू शो दैट वीडियो.
श्योर.
बिकॉज दैट इज़ अ साइन ऑफ इंक्लूजन दैट यू आर ट्राइंग टू क्रिएट, एटलीस्ट इन द कंट्रोल्ड एटमॉस्फेयर, कि जहाँ पे पेरेंट्स है, बच्चा है, एटलीस्ट बच्चे को लगेगा कुछ दे हैव वन समथिंग.
They have. It's a very big milestone.
So let's watch that video.
It melted my heart when I came across these videos of children on the spectrum being celebrated post-ATM. Generally, the scenario is quite unempathetic. You go to a hospital, get cured, and get discharged. I feel parents and children both need to be changed. But you might feel, what is the need of a celebration? Because both the parents and children have been thrown into a war that is not in their control. That too, without any ammunition and tools to fill in. If you talk to any parent, they explain how helpless they feel when they are not able to connect with each other. Think of the child who doesn't even know what is happening inside him or her and is thrown into a society that is always there to judge. 1 in 50 kids are facing developmental delays. Given India is growing 2.5 crore kids per year by 2047, more than 1 crore children will be on the spectrum. So we can't wait. Without integration, India risks losing 2% of its GDP. But every celebration, every therapy session builds a brighter future. Let's act now to support these kids and their families, because their victories are ours. Let's celebrate at every step. Thank you.
Like, I can say for sure that this is something that is very sacred to us at Butterfly. Right from our first child, Sonam and me were very clear that we are not there to keep billing sessions. The real win is if we are able to take a small percentage of kids and if they don't need us anymore, that's a win. And for the last 5 years, we have been celebrating that win with the team. If you go to the internal Butterfly group, we actually celebrate every kid's discharge. It's a very big thing for us, and it might be counterintuitive to business, but I think it's not. It's really very intuitive to business, because if we are celebrating discharges, it aligns us with parents. What my customers want, what my parents want, if I'm aligning with their needs, then we are all aligned. We are all rowing in the same direction. And it is a fantastic motivation for our team as well. It is not easy to work with neurodivergent kids day in and day out. So you need that motivation, you need that appreciation,
Hmm.
not only from the child side, but
Yes.
also from the therapist side,
Yes.
to continue to do what they're doing. It's extremely tough work.
Yes.
So
yes.
this video, and we have countless such videos in Butterfly of kids who we have discharged. This is, I would say, very sacred to us. We hold this in probably the most important thing in Butterfly, I think.
And I would say that maybe other institutions, hospitals, they can also learn from this. I think this is the need of the hour.
I think so, because, and in many ways we are. So for example, we spoke about it, like Narayana Health has started an insurance scheme. In a way, that insurance scheme is aligning to prevent disease and not cure disease.
Yes.
So that is a way of aligning interests with the hospital is aligning interests with the community and the patients. And long-term sustainable institutions can only be built where interests are aligned.
Yes. Yes.
It cannot be it cannot be run like a business where you are just optimizing for
It cannot be transactional.
It cannot be transaction. It is not transaction. It is, of course, you need to make profits. Of course, the business has to grow. Of course, your shareholders will make money. They have to make money. But it is not, the moment it becomes a transactional business, I think
You've lost the battle.
You've lost the battle. And we were speaking about it, right? Healthcare is such a field that every company that has tried to be purely transactional has not become an institution. They have kind of fallen apart in the journey. So clinical excellence and while making profits, keeping purpose ahead of profits, or at least with profits, is important.
Very nice. And you talked about profound autism. I want to show you a video. This I kept because I also wanted to showcase it to people as to what it could look like. First, I'll show that video to you, and then you can corroborate with the actual findings, actual children that you have seen.
How are you, Joey? Sour cameras. Those are cameras, yes, but he asked you, how are you? Good. Good. So Joey had a behavior today. Yes, he did. He had a behavior today. The teacher said that he went after her, which means he got up from what he was doing and just went and started to attack her. And they had to restrain him. How often does that happen? At least once a day, sometimes twice. With Joey? Yeah. Every day? Every day. Why does he do it? I want to say part of it is lack of communication, but I think at this point, because they've gotten worse in the last 2 years, I would say, I want to say puberty. Hi, Joey. Hi. Louis. I'm Louis. He's wearing. I'm Louis. If you could take the autism away, would you do it? Yes. I always pray for that miracle. Down.
I think this is enough. So this actually shows that it is even more difficult for parents.
It's very difficult for families.
It needs to be celebrated.
Absolutely. Whatever wins we have need to be celebrated. And yeah, absolutely. It's a tough
Have you
journey.
seen cases like these in India?
Of course.
Also?
Of course. Come to our centers, please.
I'm assuming that parents must be crying in front of in the clinic itself as to what to do, what not to do.
Of course. But
feeling helpless that they
a lot of them also find strength from within, from peers, from family. And we are very grateful for that strength. And even if we are able to make it a little better, I think that's the purpose of Butterfly. That's why we created the company.
Yes. So you mentioned ABA therapy. In your clinics, you provide ABA therapy. Probably it is very difficult to tell parents as to what exactly it is. And you said that it is customized because depending upon the problems that the child has, you customize it. Some children would be good with drawings. You try and understand which kind of therapy should be given. So I want to show you this last reel, which has covered one use case, and then you can elaborate on it.
Want to go for a car ride? Yeah, car ride. Let's go. Which one? Show me which one. Ooh, you're hungry. Are you thirsty? You want sippy? You go potty? All right, let's go. Come on. Let's go.
So what you're seeing is actually called a AAC, alternative and augmentative communication. So if a child is non-verbal, how does the child communicate? You have to give ways and means for the child to communicate.
Okay.
So you have something called PECS, which is the Picture Exchange Communication Scheme. I might be getting the full form wrong. Sorry.
No, it is right.
Yeah, most likely right. So this child is using PECS as a method of communication. In Butterfly, we use PECS. We also use Avaz, which is again an Indian company doing some fantastic work in autism. And you're essentially giving an alternate pathway for the child to communicate if he or she is not able to communicate verbally. Extremely important.
Okay. I'm feeling a lot emotional after watching all of these videos. Even though I had watched them earlier also. Probably while discussing with you, I've gotten a better context and a holistic view of what you're dealing with. So I would like to end this podcast with this last question. You said that therapy is not cheap currently because it is a new concept in India. It is not available to everybody, and there are supply and demand gaps. So what does the future look like? How can the prices be reduced? So you came up with Get Set Early. So in 5 to 10 years, what are the new things that you're going to come up with, and how are they going to align with India? Because in India, as we have discussed, people do not have that much economic power.
Sure.
Yeah, over to you.
Two things, Piyush. First is, I think it is a matter of time before insurance starts covering therapy.
Okay.
And as therapy delivery organizations, we have to be ready for that level of transparency so that we are ready for it.
Yes.
So that is a question of when and not if of insurance covering therapy. That is one hypothesis that I have, which I would love to see become true in the next 5 to 10 years.
Okay.
The second piece is something that we are working on significantly at Butterfly, is getting precision medicine in autism and neurodevelopmental disorders. So Get Set Early was the first biomarker that we got from Dr. Pierce's lab, which uses eye tracking and gaze biomarkers. But we are really trying to create clinical phenotypes with all of the data that we have.
Okay.
We are trying to discover and correlate different blood biomarkers so that you not only have therapy inclusive education, but you're also able to say that this phenotype of child, this type of child, if presented at this age, this is the individualized therapy that is needed.
Okay.
And this is maybe the adjunct therapeutic. It could be a nutraceutical, it could be a diet. We are running multiple double-blind RCTs to come to that answer phenotype by phenotype.
Okay.
But we really want to we really want to understand the molecular basis of autism, why it is happening, subtype, different kids, create clinical phenotypes, workflows, correlate with biomarkers so that we are able to give, a precision treatment for every child.
Okay.
And it won't replace therapy, but this would essentially increase this would work as an adjunct to therapy.
Okay.
And even if it is 30-40% better, that is life changing for a family.
So from a layman point of view, I could imagine the cancer treatment. So you're saying in cancer treatment you give chemotherapy, in that you give multiple drugs and you see what is working, what is not. So in cancer, the way it is progressing is targeted therapy, wherein you give the right medicine in the first go itself. So that is what you're also trying to do.
Absolutely. I'll give you an example. 30 to 50% of kids on the autism spectrum have mitochondrial dysfunction.
Okay.
So can we identify which 30% have the mitochondrial dysfunction? Can we have some nutraceuticals and drugs that are added to the child so that dysfunction can get better along with therapy? And can we run double-blinded RCTs and check that therapy plus this therapeutic and therapy plus placebo, are we seeing any meaningful difference?
Okay. Yes.
So one thing that we are very clear is that we want to be evidence-based. We are not going to do things randomly. We are going to do it in a very scientific way.
Okay.
And we are going to get the best researchers across the world to collaborate with us to deliver this to our kids. And so that's a very targeted example of what I meant by precision treatment.
Thank you, Abhishek.
Thank you, Piyush. It was a pleasure.
Feeling very hopeful about the future, because the problem is very real, and the way you have explained it, probably a lot of people will be able to feel more hopeful and be more open and expressive about it. As in, generally in India, out of stigma, people keep on facing problems the whole life, and they feel shy to come out. I feel that this podcast will help them to get out of their zones and express the problems openly. So
thank you so much for spending so much time, Piyush.
Yeah.
Thanks.